Hi, everyone. Welcome to the Cheetah Medical webinar. My name is Jordan Swanson, and I'm the marketing manager for the company. Today, I'm excited to introduce our speaker, Marguerite Brandt. Marguerite is a clinical application specialist for Cheetah Medical. She graduated with her bachelor's degree in nursing in 1984 and spent most of her nursing career in critical care and open heart recovery. She was actually a customer first of the Cheetah NICOM before she even came to work for the company. So at the end of her presentation, one other thing to keep in mind is we're going to open it up for Q&A session, so please hold your questions until then. So without further ado, I will turn this over to Marguerite.
Hi, everybody. Thanks for joining. The goal of this webinar is to show you how to use cardiac output in hemodynamic monitoring to perform guided resuscitation to optimize organ perfusion, oxygenation, and prevent organ failure, to determine a patient's fluid responsiveness in a simple, reliable, and standardized fashion, and to understand how to use hemodynamics to drive differential diagnosis in common critical care situations. Why are you here today? Why did you take time in your busy schedule to listen to this webinar? I'm sure you're all going to come back with the same answer, and that's that you want to gain more knowledge. You continuously want to expand your knowledge base so you can provide the best care possible for your patient. We all want to make sure that our patients are getting the best care to enhance their recovery. And for those patients that did not have a positive outcome, we want to know that we did all we could. So today, I would like to introduce you to a totally non-invasive tool that can be nurse-driven and can provide you with additional information so you can optimize the care for the patient. The fact that it's non-invasive allows you to assess and intervene without any delay. You don't have to wait for a physician to put lines in. The key is early intervention. In other words, we can optimize the care and be proactive rather than reactive, in which way we can help improve the outcomes. It's called the Cheetah NICOM. The Cheetah NICOM is the only non-invasive product that's out there that's actually FDA approved, predicated on the Swan GANs, which is still considered today as the gold standard. It provides the following parameters: your heart rate, non-invasive blood pressure. The SpO2 is optional. Stroke volume index, cardiac output, cardiac index. TPR and TPRI is the same as your SVR and SVRI. It stands for total peripheral resistance in the index. Stroke volume variation, thoracic fluid content, and oxygen delivery index. The difference between the Swan and the NICOM, of course, it's totally non-invasive, so you don't have the same risks that you have with the Swan GANs. And then the other difference is with the Swan, you look at your PA and wedge pressures to decide whether you want to give the patient volume or not. Just remember, those are pressures. It doesn't measure flow. It doesn't measure volume. If you look at that number, it doesn't tell you whether that patient is going to respond to a fluid bolus or not. The Cheetah NICOM measures stroke volume. It's a flow-based monitor. So you can use the stroke volume as you give that fluid bolus, and you can see actually if the patient is going to respond to that fluid or not. And we will discuss that a little bit more later. All you need is 4 sensors, 2 sensors above the heart, 2 sensors below the heart. You can put it on the front or on the back or in a combination of, as long as you have 2 above and 2 below the heart. The Cheetah NICOM works with bioreactance, not bioimpedance. The outer sensor sends a known frequency into the chest at 75 kilohertz, and the inner sensor measures the signal that's coming back out. The Cheetah NICOM compares this signal to the original signal. Pulsatile flow created from blood being injected from the ventricle into the aorta causes a time delay or a phase shift in this frequency. It determines how much blood had to have been come out of the left ventricle into the base of the aorta to cause that specific time delay. This becomes stroke volume. This time delay or phase shift between the AC current that goes into the chest and the voltage that comes out of the chest are synchronized with the heartbeat. And you can see how consecutive measurements of the phase shift build the NICOM signal from which the stroke volume is later derived. So again, the NICOM monitor induced that 75 kilohertz current into the thorax via the outer sensors and received the voltage via the inner sensors. And then it measures the time delay or the phase shift between the induced current and the received voltage continuously. And that's how it built that NICOM signal. Let's just take a look at the results of the validation clinical studies. It's 95% sensitivity and specificity for directional changes in cardiac output versus the pulmonary artery catheter. The Cheetah NICOM is more responsive than the PA catheter. It's actually quicker to sense changes. Cardiac output readings were not statistically different. The precision is better than with the pulmonary artery catheter. The Cheetah NICOM is as accurate or better than the Vigileo, especially in unstable patients. And the Cheetah NICOM is as accurate as PICO in post-cardiac surgery patients. Let's take a look at the main applications. When your patient's in shock, we don't necessarily always know which shock state they're in. Sometimes we do, sometimes we don't. So if you look at, for instance, hypovolemic shock versus cardiogenic shock, they look exactly the same. The patient is hypotensive, tachycardic, low cardiac output indexes, and high resistance. The difference is that in hypovolemic shock, the patient is fluid responsive. In cardiogenic shock, the patient is not fluid responsive. And then also, if you have a patient that's short of breath and they have a history of both COPD and CHF, sometimes we know which one is acting up, and sometimes it's not that clear, and sometimes the doctors don't always agree on which one is actually acting up. So now if you check the patient and that patient is actually fluid responsive, then you know it can be the CHF. Anytime that you want to do guided fluid management, when you need to do like goal-directed therapy or fluid resuscitation, it can kind of help you guide so you don't give too much or too little fluid. And then just to answer that question, is my patient wet, is my patient dry? It's a question that we answer on a daily basis in critical care. And it can especially be tricky in those hemodynamically challenging patients that have sepsis, cirrhosis, or is on dialysis or cardiac patients. Also with drug choice and titration, do I need a vasopressor or do I need an inotrope? And also when you choose a drip, and you have to titrate, you can actually see what the response is, and you can kind of see the patient is doing better or no, I need to regroup and I need to try something different. The goals of hemodynamic monitoring is to obtain information which may facilitate diagnosis, treatment, and allow monitoring the response to the therapy. It also helps alert the healthcare team to impending cardiovascular crisis before organ damage takes place. And it can also help you to stabilize that patient out faster. I would like to introduce you on a very special patient of mine where the Cheetah NICOM and hemodynamic monitoring really did a big impact on his hospital course. And we'll talk about him a little bit later in the presentation. Cells and organs require oxygen and glucose delivery. As the metabolic demands change, the heart and the lungs work as a unit to provide adequate oxygen to the tissue. So when the tissue don't get enough oxygen for the metabolic demands, we're going to have metabolism taking place with no oxygen. That is anaerobic metabolism. It's going to build up that lactic acidosis. That drop in the pH in a cell is going to destroy the cell. The cell is going to die. The organ is going to die. The patient is going to die. Let's look at the factors that play a role in oxygen delivery. We need to have enough oxygen carriers, that's your hemoglobin. You need to have enough oxygen, so you look at the oxygen saturation, and then your cardiac output. What is cardiac output? Cardiac output is your stroke volume times your heart rate. So we can see the hemoglobin, we can see the SAT, and we can see the impact of the heart rate on the cardiac output. But the part that we cannot see without the hemodynamic monitoring device is the factors that play a role in stroke volume, and that's your preload, afterload, and contractility. Preload is that stretch of the myocardial muscle fiber caused by the end diastolic volume. So remember that starting law of the heart. If you increase the volume, it increase that stretch, increase the contractility, and increase the stroke volume coming out of the heart up to a physiological point. If that heart is already filled, you can't stretch it anymore and you're not able to push out any more fluid. So that's when there's a buildup of interstitial fluid if we give fluid to patients that's not responding to fluid. Afterload is the resistance to ejection, is your vascular tone. How vasoconstricted or vasodilated am I? Contractility is the force of the cardiac contractions. Fluid optimization is the most important thing for in-organ perfusion and tissue oxygenation. Standard fluid resuscitation uses a generic rule of thumb approach. Fluid optimization really means that you customize that IV fluid for that specific patient, that specific time. The goal is to give patients what they need, not too little and not too much. Now the trick is, though, is to find the objective parameter by which you can optimize that fluids. And in this situation with the Cheetah NICOM, the key parameter is the stroke volume index. So what happens when a patient becomes hemodynamically unstable? We give them fluid first, and if that doesn't work, then we go on to the next thing. Studies has actually showed that only 50% of these patients are actually fluid responsive. So 50% of the time, we're giving fluid to patients that really don't need it. So if we don't give enough fluid, we cause hypoperfusion. If we're giving too much fluid, it leads to hypervolemia and a result in excretion of atrial and brain natriuretic peptide, which cause shearing of the glycocalyx. The glycocalyx is a gel-like matrix which layers the endothelium of all vessels. It controls free movement of fluid and electrolytes. So if you damage this glycocalyx, it results in leaking of fluid into the interstitial space, leading to interstitial edema. It also interferes with the pacemaker function of the lymphatic system, causing a decrease in the absorptive function of the lymphatic capillaries. What does that mean? It means that there's a retention of protein and fluid in the interstitial space, and so what happens is there's a delay of the reabsorption of interstitial fluid back into the vascular system. The balance, there's a fine balance between the need of adequate fluid resuscitation so that you don't cause hypoperfusion versus progressive positive fluid balances causing the organ edema versus the overzealous fluid removal, and we're back to hypoperfusion. Most of the time when we fluid resuscitate these patients, we use normal saline. Salt and water overload can lead to organ dysfunction, and it's most evident in the lungs. Impact wound healing, nosocomial infections, more so in patients with acute kidney injury. So when you look at that patient and you saw edematous, if he looks like that edematous, think how the organs look like. They are edematous too. So if you have that interstitial edema on that kidney, it actually can delay the recovery of the renal function. Positive fluid balances is 5 to 10% of body weight are associated with worsening organ dysfunction and critical ill, worse patient outcome in routine surgery, and at no benefit whatsoever on renal function. And it also increases your mortality and morbidity. And then again, if we do excessive fluid removal, it can cause to renal hypoperfusion if we're too aggressive with the diuretics or fluid removal with dialysis or CRRT. So this picture kind of shows you, if you have organ edema, what impact that it has. If you look at cerebral edema, it impairs cognition and causes delirium. Pulmonary edema leads to impaired gas exchange, reduced compliance, and increased work of breathing. That increased renal venous pressure and renal interstitial edema reduces that renal blood flow and increases the interstitial pressure. So what happens, then you have a reduced glomerular filtration rate, and you have an increase in uremia and salt and water retention. With tissue edema, impaired lymphatic drainage, and microcirculatory derangements, that leads to poor wound healing, wound infection, pressure ulcerations. Gut edema leads to malabsorption and ileus. And with hepatic congestion, you actually have impaired hepatic function. Myocardial edema, it can cause conduction disturbances and actually can decrease contractility and also worsening the diastolic dysfunction. So if we look at what parameters are we going to use to guide us when we give fluids to patients so that we give them the right amount, look at a CVP. There is no relationship whatsoever of blood volume to CVP, and you can see that clearly in the slide. CVP and wedge only predict fluid responsiveness 50% of the time. In this article from Merrick, Monet, and Touboul, where they write about hemodynamic parameters to guide fluid therapy, that's what they wrote about. It's very difficult to determine intravascular fluid status in the critical ill patients. So what happens when they get unstable? We give them fluid first. In studies that show that only 50% of those patients are actually fluid responsive. If we don't give them enough fluid, we don't perfuse the organs. If we give them too much fluid, it actually increases their mortality and morbidity. So the static values like CVP and wedge only predict fluid responsiveness 50% of the time. And on the contrary, the dynamic values or the dynamic parameters actually can tell you whether a patient is fluid responsive or not. What is a dynamic value? A dynamic value or parameter is a measured response of an output, like cardiac output or stroke volume, to a defined stress, which is the fluid bolus. If we look at examples of dynamic values, number one is like stroke volume variation. That assesses the changes in stroke volume during a mechanical ventilation, or we can assess the changes in stroke volume index when we give a fluid bolus. So if we give a fluid bolus to see whether the patient is fluid responsive or not, we can do it one of two ways. We can actually do a passive leg raise, which is a bedside maneuver that gives you about 200 to 300 cc's of blood from the cavities back to the heart. It's quick, it's safe, it's reversible. A positive passive leg raise test is when you increase that stroke volume index 10% or more, and that indicates that the patient is actually on the ascending limb of the Starling curve. A passive leg raise has been validated to have excellent sensitivity and specificity to determine fluid responsiveness. And if there's for some reason, if you can't do a passive leg raise, you can do a real external fluid bolus, and it will give you the same results. So now you can see if you're on the ascending limb of the Starling curve, those patients, if they get fluid, it actually improves their cardiac performance. When you're on the flat part of the Starling curve, that fluid administration has no benefit, and it may actually cause harm. So if you're on the ascending limb of the Starling curve, you only have a small increase in your lung water, and if you're on the flat part of the Starling curve, you have a large increase of the lung water. With the Surviving Sepsis campaign actually say that you can either use static or dynamic values to guide for fluid resuscitation as long as there's hemodynamic improvement. The first intravenous or the first fluid resuscitation was documented in the 1800s when Dr. Latta was treating these cholera patients, and he was actually injecting ounce for ounce of fluid while he was carefully watching these patients. And from there, we went to the Rivers protocol where we really flooded the patients. And recently, the results of the process trial was published. They were much more conservative with fluid administration. And even though mortality rate was really not different among the three groups in the trial, it was significantly less than the mortality rate in the Rivers protocol. It also showed that there was no benefit of mandated use of central venous catheterization and central hemodynamic monitoring. Stroke volume and cardiac output indicates that there's flow. And if there's flow, there's life. Pressure does not equal flow. The fact that you have adequate blood pressure for the moment doesn't mean you have adequate flow. The fact that you have an EKG on that monitor, that doesn't always equal flow. You can have a normal sinus rhythm on that monitor, and you can have no flow. They call it the patient is dead. It's pulseless electrical activity. There are several things that can cause PEA, but the main cause actually is hypervolemia. Cardiac output in stroke volume is fundamental in hemodynamic management of critical ill, injured, and hemodynamically unstable patients in surgery. Fluid challenges and the use and titration of vasopressors or inotropes should be based on the response of the stroke volume, on the response of the flow, in other words. The only reason to give fluid is when the patient is fluid responsive. And the fact that that patient is fluid responsive doesn't mean you have to give him fluid, only when he has some kind of symptomology that you need to treat. Changes in stroke volume and cardiac output are early signs of compromise. Let's look at the stages of hemorrhagic shock. And that's just to kind of show you that you can already lose like a liter of blood before you see signs on the outside like tachycardia or hypotension. Remember, flow, stroke volume, cardiac output, it's early signs of compromise. Heart rate, blood pressure, urine output, all those are late signs. Let's review some case studies. This patient was one of those classical situations where the patient was on Coumadin because he had a mechanical valve. So he fell, he hit his head, and he developed a subarachnoid bleed that needed to be evacuated. So now he's in the ICU, he's on the vent, sedated, but they also wanted to monitor him a little bit closer with his cardiac output because of his heart failure component. So he was attached to the Cheetah NICOM, and he was doing great for several days, great cardiac output indexes, and one day his stroke volume and cardiac output just dropped off. So the nurse did the right things, checked the sensors, recalibrate the monitor, but the numbers still stayed low. So then they went ahead and they did a 12-lead EKG and they did a troponin I, and he was actually diagnosed with a non-STEMI MI. So here's the patient, sedated, can't really complain of chest pain. You can't see any changes on the bedside monitor. So the only thing that really alerted them that there was something going on is because he was attached to a flow-based monitor, a stroke volume monitor, that dropped off first and could warn them that there was something going on. So here you can see how that stroke volume index and cardiac index dropped off, and then they start to butamine, and the stroke volume index and cardiac index come back up. So again, just to show you, we monitor blood pressure and we monitor EKG, and those don't really show what's flow. And if you have not somebody or a monitor attached to you where you can kind of monitor that flow, then it drops off, then you may miss the warning signs, that early warning sign. So you cannot intervene quickly and kind of turn the patient around before the damage can take place. In this patient, it was a septic patient that was admitted and fluid resuscitated, and she ended up being like 10 liters positive. She also, during her stay, they placed a permanent pacemaker, and at that time, she was on Levophed at 23 mics per minute. Vasopressin was at 0.04 units per minute. Dovitrex was at 5 mics per kilo per minute. Her urine output was marginal, and she also had a bump in her creatinine. At that time, she had a swan in, and her PA and which CVP pressures were actually elevated. So clinically, it looks like this patient is overloaded. And what they were going to do is they were going to release this patient with Bumex. So we actually attached a Cheetah NICOM, and we did a passive leg raise on this lady. And if you look at where the stroke volume index is, and you look at the bottom there of the stroke volume index row, you see a 20.1%, and that is what the changes were in the stroke volume index from baseline to the peak of the challenge. So that stroke volume index increased 20.1%, which means that this patient is fluid responsive. Remember, 10% or higher, patient is fluid responsive. So now they held the BMX and they actually give the patient fluid. So when we compare the pulmonary artery catheter and the Cheetah NICOM, the index, cardiac index with the SWAN was 1.4 to 1.7, and on the Cheetah NICOM it was 2.7 to 3. The preload pressures, the PA and CVP were elevated, but in the Cheetah NICOM showed that the patient was actually fluid responsive. So we did some troubleshooting, make sure we can't see any variables that causing this discrepancy. But the X-ray showed that the pulmonary artery catheter was in a good place. We leveled the transducer and re-zeroed it, didn't make any changes. So then we dig a little bit further and we look for an echo report, and I actually just did an echo report that morning. And on the echo report, it showed that the patient had tricuspid regurgitation, which means that the SWAN number is not correct on patients with tricuspid regurg. It also showed that there was an EF of 65% and a cardiac index of 2.7, which correlates with the numbers of the NICOM. The other thing that it showed is that there was a moderate to large pericardial effusion, which can explain increase in preload pressures. Because of that fluid around the heart, it can actually increase that pressures. So they end up giving fluid to this patient, and they were able to wean the liver fat down to 16 mics per minute. The next day, we repeated the passive leg race, and at this point in time, she only increased the stroke volume index 6.5%, which showed that she was not fluid responsive at this point in time. Later, she went for a pericardial window, and they drained 600 mils of pericardial fluid. After that, her preload pressure came down, and they were able to wean the liver fat down to 13 mics per minute. And this just going to show two things. The fact that the device that we use is invasive doesn't necessarily mean it's more accurate than a non-invasive product. And then the other thing that I want to point out is you can see here the difference between using pressure versus flow to determine if this patient is actually fluid responsive. And now we're getting back to the patient that I told you in the beginning that was a very special patient to me. He was a 69-year-old male that presented to our ER. He had hypotension, severe muscle ache, nausea, vomiting, and diarrhea. He was hypoxic and dyspneic. He was actually in perfect health prior to admission. So he ended up on BiPAP. They gave him fluids, and they started dopamine on him in the ER. His first set of troponins were really elevated, so the emergency took him to the cath lab, but his coronaries were clear. And he ultimately was diagnosed with viral myocarditis and cardiogenic shock. So when we look at his hemodynamic profile, his cardiac indexes were really marginal. He had an increased afterload. His SVI was 21 to 23, and a normal SVI is actually 33 to 47. Blood pressures, systolic blood pressures were like low 100s, and his heart rate was right at a 90s range. Clinically, viral myocarditis, cardiogenic shock with a compromised EF. He was on dopamine and Primacor. He was short of breath, on BiPAP, and if you look at the X-ray, it looks like pulmonary edema. The urine output was decreased. They tried to diurese him, but he didn't really have a great response with it, and his creatinine actually was up to 2.7. So with viral myocarditis, they go on failure, and you need to try to get the fluids off. Well, the diuretics didn't really work, so what's the next step? He's going to need dialysis, but his hemodynamics is so compromised that he wouldn't handle conventional hemodialysis, so that's why they decided they're going to do CRRT. I just happened to be in the room next door when they delivered the supplies for the CRRT, and that's why I know they're going to do that. And as I walked past the room and glanced into his room, I saw the numbers on the NICOM, and I remember going through my head, I don't know how he's going to tolerate this. So I went in there and I started assessing him, and I did a passive leg raise on him. He actually increased his stroke volume index by 21.6%. So this guy was actually fluid responsive. So now I went back to my pulmonologist and I explained to him what I saw. And we had a long discussion, and he said to me, well, maybe that x-ray could be pneumonitis. And then he called a nephrologist, and they had a conversation. And so they decided what we're going to do is we're going to give him a liter fluid bolus, and then we're going to give him another fluid liter at a slower rate. And now, I had to give that cardiogenic shock patient a fluid bolus. And I was a little concerned because, he had a high afterload, compromised EF, and his contractility was not very great. So what I did is, and his blood pressure was kind of marginal, so I started giving the fluids, and after I got a little bit of the fluid in, I increased the Primacor to maximum dose. And the Primacor is that positive inotrope, and it's also a very potent vasodilator. So it gives him that increased contractility to pump, and it also makes it easier for him to pump because of the vasodilation. So you promote that forward flow. And I absolutely scrutinized the numbers, and as you can see, the cardiac output, cardiac index kind of went up. The blood pressure kind of hung in there, and then his afterload, the TPRI, came down as he vasodilated. And you can also see how his stroke volume and stroke volume index increase with the fluid bolus. After a few minutes, he started to make a little bit more urine, and it's only a nurse who gets happy about urine. So by the end of the day, he actually looked a little bit better. We were able to kind of wean down a little bit of the dopamine. But now the cardiologist came in, and he didn't feel comfortable with the values of the NICOM. So he was convinced because of his viral myocarditis that this patient needs to be diuresed. He felt like if he put a swan in, that his wedge was going to be 25, but he didn't want to put the swan in. So what he ended up doing, because he was so convinced that that's what he needs to do, is he ordered diuretics. And here I am, caught in the middle, and you saw what improvement you got today by giving that fluid, and he was fluid responsive. And now if you're going to give the diuretics, you're going to counteract all this effect. So I called the nephrologist, and I talked to him and explained the situation, and he told me, I told him, I said, I really don't feel comfortable giving this diuretics. And he said, no, I don't want you to give the diuretics. We picked the course. We need to stick to it till it proves otherwise. So we ended up giving him whole the diuretics, and we kept him positive for the next 3 days before we started diuresing him. We turned him around, and he went out of critical care within a week, no intubation, no CRT. He went home shortly after with no residual whatsoever. And this, again, too, is to kind of show you that with these critical ill patients, it's very difficult to assess their intravascular fluid status. So now if you have a dynamic tool that can help you assess whether that patient is fluid responsive or not, it can kind of guide you in the right direction. A year later, he sent me this note on Valentine's Day, and he says, Happy Valentine's Day to you. 1 year today I was in the hospital, and you helped save my life. Thanks again. Conclusion. Know how to interpret the data. Monitoring is not therapy. The fact that you have the monitor hooked up is not going to help your patient. You actually need to look at trends, need to look at the data, and if there's signs that the patient you need to intervene, it's not going to get better if you don't do something about it. Hemodynamic monitoring data can provide valuable information to guide fluid resuscitation and optimize oxygen delivery to prevent organ failure. Information obtained from hemodynamic monitoring may help prevent intubation, dialysis, decrease in post-op complication, and decrease in length of stay. Changes in hemodynamic values may provide clinicians with early warning signs of possible complications and opportunity of early intervention. Stroke volume equals flow, equals organ perfusion, equals life, equals the next vital sign. Thank you very much, and we'll take some questions.